our last session of the day, which in some ways brings us full circle, because we will hear it's a fireside chat between two philanthropists, and I know we started the day with the power of now making the case for giving to India, and we're going to hear, I think our description in the agenda does a really good job, so I'm going to lead with that in saying that both these speakers don't need a whole lot of introduction. He's a leading figure in Indian American philanthropy. She's the next generation of a large philanthropic family. In this conversation, we're interested in seeing Sunil, Wadhwani, and Sapphira Goradia speak to each other about navigating the complexities of giving to India from abroad, of scaling impact across the length and breadth of the country, of injecting sustainability into philanthropy by bringing the next generation into the fold. So with that, if I could please invite Sapphira and Sunil on stage. Thank you.
Listen, we are the last session between all of us and fine wine. So the more you applaud, the quicker we will wrap this up.
So I am very happy to be back on the stage with Sunil Wadhwani, who has been really a leader in diaspora giving to India and in strategic philanthropy over the past several years. Sunil started the Wish Foundation in 2014, which aims to transform India's primary healthcare system through really a unique public-private partnership that focuses on innovation and scale. And because that wasn't challenging enough, in 2018, Sunil and his brother Romesh started the Wadhwani Institute for Artificial Intelligence, which develops and implements AI solutions towards a range of societal problems. So, Sunil, we only have half an hour, if that, and there is a lot I would like to pick your brain on, so we'll just jump in, if that's okay.
Sure.
So first, could you just tell us a little bit about the Wish Foundation, how it operates, and what got you interested in the primary healthcare space in India in the first place?
Sure. So just for some context, I grew up in India, came to the US for higher studies, went to Carnegie Mellon, which is how I'm still in Pittsburgh many years later. I started my first company, was a medical device company. I never wanted to work for anyone else. And CMU, masters, etc. I thought, great, this is going to be a huge success. 5 years later, the company went under, right? 5 of the most tough years of my life, lost my life savings, etc. But you learn some lessons. Then I started my second company, which was an information technology company, and I almost drove that under too. Okay, the first 2 or 3 years, we almost went under several times. Fortunately, we survived, slowly grew, took the company public many years ago, and then sold that 3 or 4 years ago. Along the way, then I learned a lot of lessons on reflection on kind of what works in scaling things up and what doesn't work. Along the way, I've also had the privilege of working with 45 or 50 startups very closely in the US and in India. These are venture-backed, angel-backed type companies. Over the years, about half of them have gone under. Investors have lost every penny. Maybe 15, 20% have done really well, and the other 30% are somewhere in between. So again, you learn some lessons about kind of what works to scale things up, what doesn't. So as this was going on, I'd been funding 2 or 3 nonprofits in India in the healthcare space. I have this affinity for healthcare. And I was giving them money for capacity building. And this was starting maybe 20 years ago. Interestingly, through all of these years, neither of these NGOs was able to scale up for a variety of reasons we can talk about. And to me, in fact, those are the exact same reasons most for-profit ventures in the US or anywhere in the world also don't scale up. And it doesn't have to do so much with lack of money or resources, et cetera. It has to do more with the mindset of the founder and giving up control and things like that. So finally, 5 years back, these NGOs weren't scaling up, but thanks to them, I had traveled to remote parts of India. I had seen firsthand how bad things are in the healthcare field when you get into really the low-income states in India, right? The Bimaru states. Bihar, Madhya Pradesh, UP, Rajasthan, Odisha, etc. These states account for maybe 30 or 40% of India's population, but they account for 80 or 90% of India's problems, whether it's in healthcare, whether it's in education, etc. So I thought, let me start my own NGO, and see if we can develop a model on how we can apply some innovation and technology to addressing primary healthcare. Why primary healthcare? Because that's the foundation of healthcare, and if that system doesn't work, primary health, the rest of the system doesn't work. And in large parts of these low-income states, these systems really don't work. So I hired a small team. I set up the NGO, hired a small team, 5, 6 people. We developed a model on kind of how we'd use innovation in primary health. And now what do we do with it, right? We had no credibility, no experience, no one had heard of us. But again, we were looking at states like Rajasthan, UP, and so on. And in Rajasthan, this lady, Vasundhara Raje, had just been re-elected as chief minister. She had been chief minister earlier, but had been voted out of office. And this time, she seemed to be more serious about actually doing stuff that would help people in healthcare, education, and so on. So we decided maybe that's a good state to approach. And we did a lot of research, district by district, on what the gaps were in the state. We took our little model, went and met someone in the health ministry. And to his credit, he liked the idea. Again, we had zero experience, zero, anything. But he said we have to take this to the health secretary, get his approval. We went there. He liked the idea. We had to go to the health minister and finally the chief minister. Net, they all said, yeah, this is good. Let's try it out. So lesson number 1 over there, right there for me, was the following. And I think this applies to all of us. When we talk about partnerships with government in India and in other developing countries, there are lots of horror stories. And we'll talk about a few of those, I think, maybe a little later. But on the good side, I'll tell you, never before have I seen in India, and I think this is true in most developing countries, as many people in senior positions, including politicians as well as bureaucrats, who are now hungry for good ideas. Whether it's in healthcare, whether it's in education, whether it's in livelihood, skills training. And they're willing to give it a shot. They're willing to work with the private sector, whether it's nonprofits, whether it's the for-profit sector. So I think that's a dynamite thing. So we got started. And basically our pitch to the Rajasthan government was the following. Here's our model for using innovation. Take your worst performing districts from a healthcare standpoint in all of Rajasthan. Within those districts, take your worst performing primary health centers, the worst. Give them over to us. Here's the interventions we'll put in. Here's the 30, 40 quality metrics we'll track. We'll cover 100% of the cost for the first 6 to 12 months. But once you find that we're meeting these quality metrics, then you take over 80% of the cost, right? Shockingly, they agreed. Okay, they said, okay, fine, we'll do this. So we thought, okay, they'll give us 3 or 4 or 5, health centers, and we'll kind of show what happens. They gave us 200 health centers, 200, and I had a little team of like less than 10 people. We had 90 days to take over 200 health centers. Again, in the worst parts of Rajasthan, tribal areas. And these were places that were ugly. They had garbage outside, garbage inside. You didn't want to breathe. There were no doctors. Equipment didn't work. Medicines were stolen, blah, blah, blah. 90 days, we had to hire 300, 400 people, get these staffed up, get them clean, blah, blah, blah. Cutting a long story short, we went in, did all that stuff, thanks to my team, and things started working. And within, I'd say, 6 or 9 months, in all of these 200 clinics, the average patient flow per month had been around 15 to 20,000 patients. 9 months later, we were treating 70 to 80,000 patients a month, because now they knew places were clean, doctors there, medicines there, blah, blah, blah. So this started growing, and to the credit of the Rajasthan government, they actually did what they said they would do. Once they saw that the results were there, they started picking up a large bunch of the cost. USAID heard about this, they came, they were impressed, they gave us a little grant. A year later, the new Aam Aadmi government came into Delhi, Kejriwal. They heard about what we were doing in Rajasthan, so we got a call from the health minister, Satinder Jain. He said, I've heard about the stuff you're doing in Rajasthan, but that's a rural program. We have this Mohalla clinic, this ambitious clinic program idea in Delhi. Come and just talk to us about what you're doing, and let's see. So my team went to his home. This was at 9 p.m. one evening, and I believe the meeting went like 2 a.m. He asked that many questions. And then he said, will you be our partner over here in Delhi? And can you bring your model of innovation over here? So we said that, and now we're running 300 clinics in Delhi in partnership with the Delhi government. And since then, now we're in Madhya Pradesh, we're in UP, we're in Assam, and so on. what's interesting is that we've had a lot of learnings along the way. So one was government is a challenging partner, but that's the only way to get scale. It doesn't matter what you want to do, whether it's in India, Bangladesh, Ethiopia, Liberia, in developing countries. When you're talking about the poorest of the poor, there is no private sector over there. There are no for-profit models that I've seen. In India, there are maybe 20 people that I know of, trying to do for-profit primary healthcare models in these remote areas. There's not one that's working. Not one that's, unfortunately, I wish they were working. So you have to work with government. And like I said, there are good things. You have to find supporters up front, etc. The second thing I learned was all of the same lessons I had learned the hard way in trying to build tech companies in the US, all of those same lessons apply in trying to build nonprofits in India or anywhere else. And we can talk in a couple of minutes what those lessons are. The other thing I learned, and all of us learned at Wish Foundation, was all innovation is not equal. So today we've been talking about a lot of innovation and technology and so on. And initially when we started 5 years back, we would come across innovators in India. We've probably connected with over 1,000 healthcare innovators in India. And someone had a great idea for doing these blood glucose tests for 80% less cost than is the case. Someone else had a great idea for doing urine analysis tests. The big problems were, whether you're looking at poor, low-income rural areas or urban slums, the biggest problem is lack of medical personnel. Why would doctors go over there if you or I are a doctor? If you can earn 10 times more money working in Bombay or Delhi and your wife is happy because she has a social life, or your spouse and your kids can go to a good school, that doesn't happen when you go to tribal Rajasthan or some other place, right? So lack of doctors, lack of pharmacies, lack of pharmacists. So then we kind of pivoted, and instead of looking for these point solutions which we had been excited by, but which really didn't make much of a difference, we said, let's take a look at what the 4 or 5 biggest problems are. And they are, like I said, lack of doctors, pharmacies, pharmacists, inadequate patient records, corruption is a giant problem. Delhi, for example, I shouldn't be using names of places, but the government over there, or in most states, they'll pay these government doctors to see 50 patients a day or 60 or whatever the number is. Doctor will see, and they've got these big registers where they'll write the names. Doctor will see 10 patients, write down name, diagnosis, blah, 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 and then create the names of 40 more patients. After an hour, leave the government clinic. He or she has a private clinic, 200 yards away. The staff there knows anyone who comes after the first hour, you tell them Dr. Saab is in his private clinic where they have to pay, even though, and that's the way it works. So in Delhi, for example, we came up with a really interesting tablet, iPad-based solution, where instead of registers, starting 2 years back, you walk into one of these mohalla clinics, the doctor has to take your photograph on the tablet. Within 30 seconds, the doctor enters your name and basic diagnosis and so on. Now you can't suddenly create patients, right? It's real life. Corruption, that form of corruption has been wiped out virtually. And because of this, obviously, doctors did not take to this system. We went to the government. We said, you have to lay down the law. 90 days, any doctor who doesn't do it will get fired. They did that, meaning they didn't fire, but they put out the threat. And now we have a 95% kind of rate. So that kind of corruption has come down dramatically. So the doctor takes the patient, the picture of the patient. That feeds into the start of an electronic health record, which these clinics have never had before. The next step is then we've developed, working with local innovators, a suite of smart diagnostic devices. So things like, again, urine analysis, blood glucose, etc. But what these things do is they not only take your vitals, but they can transmit them instantaneously, real time, to a doctor who might be sitting 200 or 300 miles away. Because in these remote areas, there is no doctor. So to replace the doctor in these areas, kind of like Sanjeev, you're doing, we bring in doctors by telemedicine. So in each of these remote clinics, we have a screen, low bandwidth connection because you don't have high bandwidth in these areas. So these might be out in tribal Rajasthan. We have a team of doctors sitting in Jaipur. So all those smart diagnostics, which have been taken by a technician, you don't even need a nurse to do that. Data goes to the doctor. Doctor then consults with the patient live. You can see him and he's talking to the patient. And in most cases, 80 or 90% of the time, a medicine is prescribed. But now there's no pharmacies or pharmacists. So working with a local innovator in Bangalore, we came up with a medicine vending machine. It's like a Coke vending machine. but it's got 88 of the most commonly used medicines in India. So they're stocked over there. The doctor on the screen from 100 miles away will hit a button on his keyboard. The right medicine drops out in this remote area, and the doctor tells the patient, look, 1 pill in the morning, 1 pill in the evening, whatever, etc. That takes care of it. Data from the machine goes into a supply chain management system so that we can now track inventory of medicines and so on, which has cut down dramatically on stealing. Otherwise, that used to be a big problem before. And now we're looking to see how do we apply data analytics, how do we apply AI to this kind of thing. So for example, in Delhi, if at one of our clinics in this mohalla, we see two cases of dengue fever. Tomorrow in that mohalla clinic, we see 3 cases of dengue fever. We then inform the Delhi government, here's where it's likely to happen next. Send out your people, spray the areas over there before this kind of spreads. So that's the kind of model we've developed at Wish. Again, the focus is these low-income states. So we've gone from 1 program in 1 state 4 years ago. Now we have 8 programs running in 5 states of these low-income states. The other interesting thing that's happening, and this may be interesting to some of you, regardless of whether you're in healthcare or education, etc. We all worry about scale, right? All day long we've been talking about scale, 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 but scale isn't easy to do. And it's not just a function of resources. How do you get leverage? So what I kept telling our people is that, look, it's fine that we're running 400 clinics, and since startup, we've treated over 16 million patients, et cetera. That's wonderful. But we've got 700, 800 million people in India who do not have access to good quality primary care. There's no way we can run enough clinics. So state of Rajasthan, as an example, we're running 200 clinics. The government of Rajasthan is running 10,000 clinics. So I said, we've got to go from running projects, which we are doing, and running all these clinics. Now we have to add on running programs where we can go in and advise states on how they can improve their systems. So we've just started doing that. So the government of Rajasthan asked us to set up a technical advisory unit so we can help them adopt parts of our model in all these 10,000 clinics that they run. Then the state of Madhya Pradesh came, so we set up a technical unit and advisory unit over there about 6-9 months ago. We've done the same thing in Assam. Now we're talking to the states of UP, Jharkhand, who was mentioned prominently today. We're speaking to that government in Chhattisgarh. So again, the idea is we start with projects. Now we're going into programs. The next thing we're trying to see is, can we develop some platforms which we can give out to other people, and that we don't have to run for us, run ourselves. So as an example, and stop me if I'm boring you with too much detail, but the Modi government 2 years back in 2017 came up with a new national health policy for India. It's the first new national health policy in 20 years, okay, that we have in India. For the first time, they've put primary care front and center. And they've got 2 basic strategies for dramatically improving primary healthcare in India. One is the government currently runs, all the states currently run 153,000, 1.5 lakh primary care clinics around India, right? That's a giant number. And that caters to the 700 million, 800 million people. But 30 or 40% of the system is absolutely broken. Again, lack of doctors, medicines, equipment doesn't work, and so on. So we are now talking to the government of India to say, look, do you folks want to adopt our model? We'll give you the standard operating procedures. We'll give you the data architecture. We'll give you the dashboards on how you measure quality, et cetera. So now the government is very interested in, so they've sent out teams to kind of look at what we're doing. So again, the idea is we started with projects, with implementation, and we're not going away from implementation because that you see what works and what doesn't work, from an innovation standpoint. Plus, it differentiates you from everyone else out there because you've got McKinsey and BCG and all these guys giving all this high-level great advice to governments very expensively, but they don't have the on-the-ground experience. So we will continue doing that, but we're adding on these programs, as I said, this advisory work. Now we're doing platforms. So another example of a platform is now with 400 clinics, I know that all our clinics are not of uniformly good quality. I'm sure some are not doing too well, some are doing better, et cetera. So we've developed internally a mechanism for assessing the quality of these clinics. on 5 big areas: infrastructure, personnel, finances, et cetera, customer satisfaction. And we have some metrics in each. So now we've started doing this, applying this to our Jaipur program, Rajasthan program. So when we were meeting a senior person in the health ministry, we just happened to mention to them that, look, here's what we're doing with our program. You've got these 153,000 primary health centers around India that you want to improve. Would this dashboard be interesting to you? And they've said yes. So now we're trying to see how do we adapt that for larger scale use. So those are examples of kind of the broader impact that I think all of us in this room can have beyond the direct implementation work that we do. I mean, the direct implementation informs what we do. That's how we learn kind of what works and what doesn't work. But all of us aspire to have kind of larger impact, and this is kind of a way to do that. And obviously, the final level is policy. So if we can go from projects to program to platforms to policy, now we can have impact. So sorry for that long-winded answer to your
it's all interesting.
Short and good question.
I have 7 more questions within that I'd like to ask, but I'm going to switch tacks a little bit.
Yeah.
So thinking about your philanthropy, you've decided both with the Wish Foundation and with the Wadhwani Institute for AI to really create big bet ventures in India itself. With our philanthropy, we've decided to fund existing ventures that we think can scale across the country. There are a lot of different ways to do philanthropy very strategically in India. But for those of us who are here in the US and just thinking of getting started, the prospect of funding in a country that's on the other side of the world, even if it's our country of origin, can seem very daunting. So what advice would you have for people who are interested in funding in India but are unsure of where to get started? What you were talking about is fascinating and also complicated. So for those of us who are here who aren't able to perhaps create organizations on the ground in India, where would you recommend people get started?
So I think we've heard the answer today. It's with Meera and with Deval. Absolutely, because what didn't exist 20 years ago in India, but what is there now are, I think, 3 or 4 things, which make this to me a golden era for having impact, for making change, whether you're a funder, a foundation, whether you're running an NGO, as many of us are in this room. Like I said, government is very receptive now, more than they've ever been before. There's innovation out there to be applied in every field, whether it's education, livelihoods, skills training, healthcare, etc. There's a number of innovations out there, but one has to be very discerning. Like I said, all innovation isn't equal. And now there's this ecosystem that we've heard about today. So for anyone interested in investing in India in charitable giving, I think number one is organizations like Dasra. There's an organization based in the US called Indiaspora, which we are familiar with, which is kind of an organization that brings together Indian Americans, and in fact, encouraging them to give to India. So just as a quick tidbit, our best estimate is that Indians in the US now give maybe $1 to $1.5 billion to India in charitable giving every year. However, we have the capacity to give $3 to $4 billion every year if we give at the same rate that Americans do. And we all know that the Indian American community is very successful. So Indiaspora is trying over the next 5-6 years to see if we can double the level of giving from US to India. So Indiaspora is another great organization to connect with that knows kind of who's working in India or not. We heard earlier today from Deepak Raj talking about the India Philanthropy Alliance, which is a group of 13 now, but it'll soon be 20 to 30 of the leading NGOs in India in a variety of fields who have shown they can scale up, whose finances are very transparent. So between Dasra, India Philanthropy Alliance, Indiaspora, and there are other such organizations, it's, I think, much easier now than it ever was before to say, look, I want to give to education. Pratham has a great model. Let me help them. Or Ekal Vidyalaya has a great model. Or Dost Education has a great model. I want to give to healthcare. Well, Nalini Saligram at Arogya World has a great model. So there are many of these channels that can be used. Don't go the way I did, which is trying to set up something. We've talked about the good side, but there are lots of challenges and issues involved.
So the work that you're doing in your philanthropy really requires a long-term lens towards sustainability and
Yes.
really consistent iteration and innovative thinking. I am curious, as your philanthropy evolves, what role, if any, does the next generation of your family play?
So that's a great question, because all of these, everything that all of us are working on are all long-term initiatives, right? These are not 3-year, 5-year type deals. These are 10, 20, 30-year deals if you want to impact education, healthcare, whatever. So in my case, both my kids are in their late 20s. They're both in New York. My son, who's been working for Morgan Stanley for the last 5 years, called me 3 or 4 months ago, and he says, "Dad, I'm tired of helping already wealthy people get a little wealthier. I want to do something that has impact." I said, "Wonderful, I totally get it." My wife was all pissed off. "Why do you want to leave Morgan Stanley?" I said, "Great, I think that's wonderful." And I said, "But what do you want to do?" So he said, "How about if I go to India and work with our foundation in the field, in remote Rajasthan, do all this stuff?" So he was just there. He left Morgan Stanley. He's been there for the last 2-3 months. He just came back. And he's come back with a whole lot of really good ideas. When I go to India every 2 months, but I go for 4 or 5 days at a time, and I meet with our team, and I go to all our, not all, but I go to our clinics. But he was there for 3 months. So he's come back with really in-depth information and ideas. So it's great to see him connect. My daughter, who works for a healthcare startup in New York, she's very interested. So she and her new husband are heading to India in February to spend time with Wish. You are doing this, Sapphira, in your foundation. You're so involved in getting stuff done. So I think for those of us at a certain age, I'm not that old, but I'm looking at Deepak and these other guys over here. It's great to see kind of, the next gen kind of coming in and, which ensures longevity.
In a few years, Sunil.
In the for-profit world, management teams often dread seeing a next gen come in because it means nepotism, it means this and that. In the non-profit world, they love it because it means sustainability. And when the next gen gets connected and engaged and hooked by this, it means that, yes, we can actually, over 20 years, have some results.
It's a great way to frame it. So I think we have a couple minutes if anyone has
any questions? Comments? And feel free to disagree with anything I said. Neelam? Yeah.
I'm just going to ask you, it may be a sensitive question, but personally, how much have you invested in this whole 4-year, 5-year, and 10-year? If you want to answer. I'm okay.
So in the healthcare foundation, I've committed $60 million over a 20-year period. And the basic thing I told our folks is the following, my team, right? I said I wanted 10x leverage on every dollar my family puts in. And the way I've told them to do that, and we are pretty close to this. So like I said, in our programs, we like to get government to cover 80% of the cost because these are government programs. And if they're not willing to pay for it, they don't see value, why should we be doing it? And then we try and find other funders, that remaining 20%, that we can share 50-50 with other funders. So USAID has come in. In our AI Institute, Google just gave us $5 million because they are, Google gave us $2 million. Gates Foundation just gave us $5 million. Because we're doing some really interesting stuff on the AI side. We're applying AI in areas like tuberculosis. How do you detect tuberculosis earlier? Because right now you have to get a chest x-ray, right, to get diagnosed. Well, in rural India, there are no x-ray machines that work. In urban slums, there are no x-ray machines that work. We're trying to develop a way just by coughing into a smartphone, can it detect whether you have TB, how severe is it, what do we do, etc. We're applying AI in areas like farming. We hear about all the thousands of farmer suicides in India, but it happens throughout the developing countries. And the suicides are mainly because farmers lose their crops to pests. So 2 years ago, and this happens mainly in cotton farming, not in wheat and rice and all. So 2 years ago, India lost almost half its cotton crop. Imagine, half of India's cotton crop to one pest. Because right now the systems in India for detecting pests take 3 months, and by that time it's too late, you've been wiped out. So we've come up with an AI solution that's in field trials where you find out within 2 weeks. If there are pests, you can take immediate action, get the right amount of pesticide in only where it's needed. Right now they spray pesticide on everything and it's destroying farmlands throughout India and other developing countries. So anyway, so that's the commitment. Yeah. So
Maybe one more question.
Two quick questions. Whenever we try to go to scale, a
Yeah.
problem which hits us right at the face is trying to find people,
yes,
staffing up to deliver.
absolutely.
So how did you take care of the challenge? And the second question is, you talked about taking over primary health centers from the government. Are you also working towards an exit strategy?
Yeah, absolutely. So I'll answer the second one first. So yeah, the exit strategy is to turn these back over to the government. So out of the 200 clinics we were running in Rajasthan, we've given 50 back to the government. And we try to ensure that the quality doesn't decline, because that's the obvious concern, and it does decline. But the dashboards that we put into place, we give to the government so that there's some pressure on them to kind of keep things going. And our model is different. So Rajasthan, we run these clinics, all the staff work for my foundation, etc. Delhi, our model is very different. There, all the staff work for the Delhi government. We provide our innovation model, and we have about 20 people overseeing these 300 clinics. So any issues, they come to our people, but that way they're covering 90 or 95% of the cost. So each model is different. And the idea over time is it should migrate back to government, hopefully in a sustainable way. The talent issue is a huge issue. It is a giant issue, and we deal with it as much as anything else. And there are two aspects to the talent issue. One is just the shortage of talent. So for example, in my own foundation, I promoted our program head, who was our COO, to being the CEO, okay, about a few months ago. We've been looking for a program head for 6 months. Haven't been able to find one yet. And they are out there. The problem is there's so few really good program heads in health. And the same is true in education and livelihoods, etc. And they're in such high demand, it's tough finding them. I'm looking for a head of digital health. Haven't been able to find one. And if anyone has any recommendations, I'd appreciate it. So that's one problem. There's a huge shortage. And compensation levels are going up dramatically. A position that maybe 3 years back cost 20 lakhs, today costs 50 lakhs, right, for people of this caliber. The second challenge is the following, and this is a deeper challenge. We all talk about scale and scaling rapidly, etc. It is very tough finding people in the nonprofit world with that mentality. Not just in India, in the US. I was on the board of United Way Worldwide here for several years. It's a $5 billion charity. We would grow at 2% a year, be very happy, no thought about innovation or any other stuff. So in the nonprofit world, trying to find leaders, whether it's CEOs, COOs, program heads, who can think, okay, how do we get from here to here, in the next 5 years or 10 years, is very tough to find. And there's this control mentality, that you find with all, not just with nonprofits, but even in Silicon Valley, I'll tell you, 80% of the venture-funded companies over here will not return a single dime to their investors. And the single biggest reason is the founder CEOs aren't able to let go. The same thing happens in NGOs, which is why out of 3.5 million NGOs in India, how many have truly achieved scale? Maybe 100, maybe 50 out of 3.5 million, right? So that mentality issue is a much deeper issue that we all have to keep kind of struggling with.
Okay, we are getting the hard stop from Neera, so we're going to stop here. But Sunil, thank you so much for sharing your insights
Thank
and
you.
experience.